Good afternoon. Why don't we go ahead and get started? So it's really a pleasure for me to introduce the Jill Joseph Lecture and our named lecturer today, Dr. Stephen Thomas. Before I introduce Dr. Thomas, I'd like to introduce the Jill Joseph Lecture. So Jill had really a remarkable career course here at Children's and even beforehand. Initially, she trained as a PhD behavioral epidemiologist, became very productive and very respected. Her scholarship focused on psychosocial factors in those at risk for AIDS. During the course of her work, she realized that medical training would advance her research. So she took a pause, she went to medical school, she did a pediatric residency, and then she came back to research. In 1997, Children's was very fortunate to recruit Jill to come and direct what is now the Center for Translational Research. At Children's National, she established herself as a strong hospital-based pediatrician. Her research in health disparities was supported by a series of NIH R01s. And all the while, I know this by report, and I had the pleasure of working with Jill a little bit before I came to Children's. She really was an exceptional leader of the center, and she was the founding director of our CTSA program, the CTSICN. In addition, Jill's leadership and vision was a major contributor to establishing the Collaborative Center for Health Disparities, which, as I understand, is now in its 16th year of NIH funding. This partnership includes Children's National, Johns Hopkins University, and Howard University. It supports research, training, and outreach to address health disparities, and also supports the Health Disparities Special Interest Group, that is sponsoring our speaker today. At Children's, Jill was really a revered and sought-after mentor, a principled, demanding clinician, a passionate investigator who addressed the determinants and possible solutions regarding disparities in health. Jill left Children's in 2011 to become the Associate Dean for Research at the Betty Irene Moore School of Nursing at UC Davis. This lectureship was established to honor her administrative leadership, her excellence as a mentor, and her many research accomplishments. Unfortunately, Dr. Joseph wasn't able to make it back to the East Coast for the lecture today. But she sends her regards, and she's really excited that Dr. Thomas is the 2019 speaker for the lecture that's named after her. So it's now my great pleasure to shift gears and introduce Dr. Stephen Thomas. By way of a brief biography, Dr. Thomas received his bachelor's degree from The Ohio State University, master's in health education from Illinois State University, and a PhD in community health education from Southern Illinois University. He's currently the director of the Maryland Center for Health Equity and a professor of health services administration in the School of Public Health at the University of Maryland, College Park. He is one of the nation's leading scholars on community-based interventions to eliminate racial and ethnic health disparities involving diabetes, obesity, hypertension, HIV/AIDS, and violence. He serves as the principal investigator for the Center of Excellence on Race, Ethnicity, and Disparities Research that is funded by the National Institute on Minority Health and Health Disparities. He's received, as you might imagine, numerous awards and wide acclaim for his professional accomplishments. And sorting through his CV, I just picked out a couple. His scholarly work was a major contributor to the 1997 presidential apology to the survivors of the syphilis study done at Tuskegee University in Alabama. I lived in Alabama for 20 years. I did research in Alabama for 20 years. That apology was really powerful. Thank you, Dr. Thomas. In 2004, Dr. Thomas received the Alonzo Smith Yerby Award from the Harvard School of Public Health for his work with people suffering from the health effects of poverty. In 2005, he was awarded the David Satcher Award from the Directors of Health Promotion and Education for his leadership in reducing health disparities through health literacy and the improvement of health promotion and disease prevention programs for adults age 50 and over. The title of his talk this afternoon is Less Talk, More Action, Addressing Unconscious Bias Among Health Professionals. Dr. Thomas, welcome to Children's.
Thank you very much.
I do want you to know that the Health Disparities League has a thought, actually it's a goodie bag, that they'll present to you at the end of your lecture.
Okay, very good, very good. Well, good afternoon.
Good afternoon.
I got to do some work here. Good afternoon.
Good afternoon.
Now, when I'm looking at my watch, it used to be the watch only told time, but my watch is telling me to stand up,
take a deep breath, all this kind of stuff. So if I'm looking at my watch, it's not because I'm trying to figure out when can I get out of here. It just keeps talking to me. It used to give me the breaking news, and I turned that off. Because it seems like every single day there's breaking news, so much that I kept changing my presentation, because who would have imagined that we now have permission to talk about racism, white supremacy in public? The president has given us permission. So we can now find our voice. In the old days, somebody bring that topic up, it was like, who brought the skunk in the room? And so it's really an honor to come here today, particularly with a title like this, because nobody in here has unconscious bias, right? It just shows us the time that we're in. And, in many ways, it's time to look in the mirror. That's really what this is all about. Again, an honor and a pleasure to be here today and to be the Jill Joseph Lecture. You should know you have a great children's diaspora out there. So I'm getting emails from around the country. I got faculty coming up to me because they were touched by her. She touched their lives. And so it is indeed an honor. I was once asked, why do you want to be an educator? Why do you want to be a professor? And my mentor told me that to be a teacher is to touch eternity. Because each person that we touch, and the faculty in here know, when you walk across that stage at graduation, you really have paid it forward. And so what I'm going to share with you today is an accumulation of observations, research that I've done in areas that in many ways were in the margins that have now moved into the mainstream. So for the young people out there who have a passion, I would just say don't lose that passion in the course of trying to get your degrees. You have to do whatever you have to do to get your degrees, to get graduated, and sometimes the socialization process can wipe out the very reason you became a health professional. And all of a sudden the patient looks like the enemy. The patient's taking time away from your research, all these things. Oh, now I have to go do clinical work. I had a CTSI scholar tell me that if he didn't get his grant, he wouldn't get promoted and tenured. And he was trying to explain this to his mother. And his mom said, she said, what would happen if you don't get your R01 and you don't get promoted and tenured? He said, I guess I'll just be a doctor. Now, that was a very interesting observation, that just being a doctor and taking care of patients somehow was less than this academic position, career path that we're putting people on. It's time to look in the mirror. So, as you can see here in our Center for Health Equity, and we're literally 11 miles from you, many of my clinical colleagues, when they think public health and the other health sciences, they make the assumption I'm in Baltimore, University of Maryland, Baltimore, University of Maryland, College Park, two separate universities. So I am your neighbor. About 50% of your pediatric patient population comes from my neighborhood of Prince George's County, okay? So I'm so glad you guys are about to open up a facility in Prince George's County. I think it's an emergency facility. So we need to be working much more closely together. You would think that the people living in the shadows of our buildings would be the healthiest in the world, given all the medical firepower around, but they're not. So we believe it's time to build bridges, build trust, build healthy communities. So we'll see if this technology works. So we're coming up with some very interesting anniversaries. We had the 50-year anniversary a while back of the March on Washington, and an undergraduate student produced this piece of art here. And I've used it ever since, because every single year the freshmen get younger. The freshmen today were born, they were born I'll have a class like this, and there's some people who don't know who that is. We have young people born at a time when all the benefits of the civil rights movement have been won, so we don't talk about it anymore. We have students who come from all over the world who don't know the history of America and race. And so I've kept it on there because it's not that long ago, and the battles we're fighting are almost the same ones, and yet we can forget how we've gotten here. So what is your dream as a health professional is very important. So I'm not going to make you take the Harvard unconscious bias test, but at least like to know if you've even heard of it. Look at these hands. I should take a photo. And so it's very interesting. I don't have to convince an audience here that it's real. And yet there's a lot of tension because most health professionals believe that they're here to serve you. You know, you have a higher purpose. You take an oath. And to imagine that you would treat someone differently simply because of the color of their skin or the accent or whether they wear a hijab or whatever, it's just unconscionable. But it happens. And it happens in ways that we would be ashamed of when we look at some of the data. So I'm going to try to take you there in a way that we can have a conversation. The issues are complex. I'm not assuming we're going to agree on everything. But I'm hoping that we can talk about it, disagree if necessary, but not be disagreeable. These are my colleagues. I was at the University of Pittsburgh for 10 years, from 2000 to 2010, and my entire research team was recruited to the University of Maryland in 2010. I share that with you because I think institutional commitment matters. So all five of us, 2 full professors, 3 young assistant professors hired at the same time. We were the largest cluster hire in the history of the University of Maryland College Park. But in the world that you guys live in, I've heard of these prestigious institutions that just take the entire dermatology department and buy the whole thing, you know. So you guys work big. But in the world I'm in, that was a big deal, especially for someone who looked like us. 3 African-American men and 1 Latina. The 2 men have since been promoted and tenured, and our Latina has been promoted as well. I share that with you because the other part of my job, my role as Associate Director of the National Research Mentor Network is in diversifying the biomedical workforce. So maybe we can talk a little bit more about how we can do that and collaborate together here. I've been part of several CTSAs around the country, including the Mayo Clinic, University of Wisconsin. I don't know why we're not working together. And plus, those places are really cold in the winter. They got warm hearts, though. University of Maryland, College Park, we have an academy. This is my commercial phase. Because as close as we are, it's amazing how much we don't know about each other. We have the Academy for Innovation and Entrepreneurship. And so one of the areas I think that might help us in breaking out of our typical way in which we try to solve problems is to come up with a whole different methodology. And so in the Academy, we use human-centered design methods. These are methods that have come out of the software industry. I think they can be extremely helpful for us in the healthcare space. We're one of the more complicated industries that has yet to be fully disrupted with new innovation. But I think it won't come unless we use different methods of trying to solve problems. So here's a potential resource for us moving forward. I have undergraduate students in our human-centered design course that I teach, building a clinic in Temple Hills, Maryland. That's right on the border, close to you folks here, and we can talk a little bit more about what that looks like. And this is our one of the scientific products of our NIH work from the National Bioethics Research Infrastructure Initiative. This is an interactive online training program for building stronger relations with minority communities. The other challenge that we have, the charge that I'm faced with, is diversifying the patient population or the human subjects in our clinical trials, and we've done a lot of work in that area. This is our 2018 Becoming a Self-Reflective Researcher training. This is maybe something, if there's enough interest, that we could actually replicate here, specifically for the children's group. And we can talk about this in the Q&A. Just a couple of things. I've stripped out all my epi slides because we sit in these rooms and we look at those epi slides about the incidents, the prevalence, the problems, and then it's over. We all leave the room. So I want to get to solutions, but I want you to know that we're in that space. We've published our results. This one here on the attributes of researchers and how they recruit minority populations. This is on the strategies of retaining minority participants in clinical trials. And this is the influence of race, ethnicity on becoming a human subject. So we can talk about these things because they still are the coin of the realm in our scientific pursuits. We have any K-12, you still use the K-12 mechanism? K-12 scholars, are they in the room here? We got one over here, okay. So my host told me we have a mix of people in here. Hopefully I have something for everybody. So in place of my epi slides, I think that what's most important is for us to understand the context, the socio-historical context that has us in the situation that we're in right now. And I think that one of the things we have to embrace is the recognition that our aim ultimately must be to uncover the social and the cultural environmental factors, get beyond the biomedical model, and address a broad range of issues like poverty, like access to quality health care, and eliminating environmental hazards in homes and neighborhoods, and implementing effective prevention programs that have actually been tailored to the community. Not just take a American Cancer Society brochure and put it in Spanish. That's not cultural tailoring. Not just putting black and brown faces on our materials. That's not cultural tailoring. We're talking about redesigning materials in ways that are actually consistent with the very culture that we're trying to reach. And so I think the other area of being in an academic institution and a healing institution has to do with what do we mean when we say disparities. And you know, academics can spend an entire symposium on definitions. Have you ever been in those rooms? I've been in those rooms. And so I'm saying, you know, at some point we have to agree on something. It's not going to be perfect, but can we agree on something and then start acting? Because the community is telling us you have already been surveying us, poking us, prodding us, blood draws, and we're still sick. They want action. And so it's in that context that we need to find out how we're going to define and agree on these things and not continue to waste time in terms of splitting hairs. So I say we go with Healthy People 2020 that says, in contrast, health disparities are a particular type of difference. They're not just a difference in incidence and prevalence. They're a difference caused by something, caused by social inequalities, caused by systematic discrimination. And the reason I say that is my young scholars who sit in rooms like this and they sit in that epi course and they see all the burdens of disease. And my minority students say, Dr. Thomas, I was just shrinking in my chair, especially when they were doing the STD stuff. It was like everybody in the room looking at me. Why is there so much gonorrhea in the black community? Why is there, they're shrinking down in their chair like this. I said, why do you think it's personal? Why do you think they're talking about you? Because the professor made no context. You would have to say, what's wrong with those people? A health disparity is caused by something. Not what's wrong with those people. What's wrong with the social environment in which they live that they're so exposed to risk factors that are associated with diseases that are totally preventable. And so I told them, now that you know this, when you're in that room again, you raise your hand, you ask that speaker, what's the context? Or else we're left with blaming those individuals for the plight in which they find themselves. Now, health equity is the attainment of the highest level of health for all people. Now, we in this country use the most well-off people in society as our basis to compare. And you know what's interesting? That the most well-off people in our society are not the healthiest people in the world. Okay? You want to really compare? Let's compare to Norway, Switzerland, Germany. We can pick any of the countries that already have universal access to care who do much better than we do for comparison. But let's not make the bar too high. So we're talking about systematic discrimination, racism, structural inequalities as the context driving health disparities. And in order to achieve health equity, we won't do that if we only focus on the biomedical markers of disease. Now, I've had my clinicians say, well, what am I going to do about poverty? I can't write a prescription for that. Do they do medical history here? Does the name Jack Geiger mean anything? Raise your hand if the name Jack Geiger. Oh, my friend, we have work to do. Jack Geiger is the father of our, what we would call the community health centers that we now take, you know, they're ubiquitous now. But Jack Geiger worked in the Deep South, and he wrote a prescription for a tractor because the problems that people were facing all had to do with access to nutritious food. And it's a long story, but a very interesting one. He wrote a prescription for a tractor. So nowadays we're hearing people write prescriptions for housing, see, margins to mainstream. And now we're looking at that as a legitimate role that you as health professionals can play. So I think history matters. These are the covers of books that describe the history of racism medicine. In fact, it would be easy to ignore if it wasn't so well documented. You know, we could ignore it, but it's so well documented. And now there's a reckoning happening right now in our country. There was a statue, I believe it was in New York, a statue of the father of gynecology that was taken down. At the University of Pittsburgh, I was in the Graduate School of Public Health. The Graduate School of Public Health was established in 1948, and the founding dean was Thomas Perrin. Thomas Perrin was Surgeon General of the United States during the time of the Tuskegee syphilis study. The building's name has been changed just last year, okay? There is a reckoning occurring. And so we've seen that. You think it's just Confederate statues? No. It's happening across many domains, including the health professionals. So it used to be that the general public didn't know about these things, but now they know faster than we do. So the book Bad Blood is the definitive history of the Tuskegee syphilis study. But you also see those other titles, the human radiation experiments, Acres of Skin. A lot of the science of dermatology came from the work in the Holmesburg prison in Philadelphia. And when the professor scientist walked into the prison yard and saw all the men, he said, acres of skin. That's what he needed for his research. Medical apartheid. So my point is that these things are now in the public domain. They're in the form of movies. They're going to be Netflix series. And all of a sudden the public is consuming this. And if you don't know what they're consuming, you may not be prepared for how they respond when you're trying to engage them in healthcare, recruit them to a clinical trial, or other things. Now, the Tuskegee study is the kind of archetype of an egregious study gone bad, and yet when you unpack it, it's more complicated than that. In many ways, the physicians who ran the Tuskegee study were the good guys. We would look at them as the progressive. They were the public health service. They were the good guys. They were the ones going down south to deliver care to people who didn't have care. And the study was designed to actually treat syphilis. Be mindful at the time when we didn't know how to treat it. didn't have good therapies. And so an organization called the Rosenwald Foundation provided the money, training minority health professionals, and they wanted to really eradicate, treat syphilis. But something happened in 1929. Know what happened in 1929? The Great Depression. And so all of a sudden, even the foundations lost their money. And so they sat around and said, we have all this data. What can we do? They cobbled together a little money and said, well, let's for the next 6 months, let's just follow these men and see what happens. And how 6 months turned into 40 years is why we're talking about it now, okay? Something was supposed to last 6 months turned into 40 years. Largely because we were at the intersection of believing that disease was different in black people than it was in white people. They actually believed that we were different species and that the disease process was different just because of race. Now, the black physicians and health professionals involved believed just the opposite. They said, we're one people, and this study will prove that we're one people. You see, interesting. Now, do you know what it takes to keep a cohort together? Now, imagine 40 years. Eunice Rivers was the nurse. Do I have some nurses in the house? Come on, nurses. My mother was a nurse. I love nurses. She loved those men. She cared for those men. She kept them together 40 years. But in the summer of 1972, in the front pages of the newspaper, that's when she found out, like everybody else, that these men were in a study that was seen as unethical. In July, when the story broke, editorial cartoons appeared in newspapers across the country. This is one. It's a very interesting one because it says here in the caption, Tuskegee study, free autopsy, free burial, plus a $100 bonus. Okay? Now here's what's very, very interesting. You want to see an example of community engagement, cultural tailoring, all the things that we talk about now we want people to do? You need to read the book Bad Blood, because they did all those things. They had one message for the plantation owners. If the men join the study, they'll be able to work harder. They had a different message for the men. The men did not know what syphilis was. And the researchers thought they wouldn't understand the spirochete. So they came up with a different term, which is the title of that book. Now, let me ask you this. Has anybody ever sat in a room like this and fell asleep? Tell the truth. Tell the truth. You know, the eyes going like the, you ever done that? Have you ever, the clock goes off and you don't want to get up out of bed? That's bad blood. Everybody had it. Everybody wants to know how to get rid of it. So people signed up because there's nothing stigmatizing about having bad blood. They thought they were being treated for their bad blood. So when this editorial cartoon appeared, and these men, were illiterate, they were sharecroppers, farmers. It says, secret Tuskegee study. It was never a secret. It was never a secret. It was published in the journals. You can find articles now in major journals, 20-year retrospective of untreated syphilis in the Negro male. It was never a secret. They used anthropologists to do qualitative assessments of the culture in Alabama to find out what were the cues that made the people tick. And one of the things that they learned in their qualitative anthropological work was that black people were afraid, their biggest fear was not being buried decently. Now, in some cultures, people spend more money on the funeral than they did when people were living. I'm telling the truth. It's an amazing thing. if you were poor and a farmer, it was not unlikely you would be buried in a seed sack. But if you joined the Tuskegee study, you'd be buried in a casket. Isn't that amazing? Live poor, die in the middle class. So why did they add that as an incentive? Because in order for them to determine the ultimate research question of the difference in terms of syphilis impact, they believed it impacted whites in the cardiovascular system. They believed it impacted blacks in the neurological system. And ultimately, they had to have an autopsy. And that was something that was not easy to get people to say yes to. But if you said yes, you got the burial insurance. Okay? So I say to you, do we not now say that we need qualitative research and focus groups to learn? Okay? But to what end? To empower the people or to manipulate the people? I just want you to hold that because we're doing it right now as we come up with our incentive. Is that amount of money too much? Is that coercive? There are a number of things that we need to think about. But for you, you need to know that the methods used were used to get these men to do what the researchers wanted, not necessarily what the men wanted. So now this is part of the cultural memory. In many communities, particularly African American communities, which is an oral tradition passed down from word of mouth, where what grandmother says has more power than what my doctor says, okay? What the barber says in the barbershop has more power potentially than what the doctor says. This is a word of mouth tradition. And now, if you've not seen Miss Evers' Boys, which is the HBO movie that won a Tony Award, it's also a play, theatrical play, written by David Felshew, who's a physician, or the jazz CD by Don Byron called Tuskegee Experiments, or what I really like and just couldn't believe until I saw it, is Marvel magazine, you know, the cartoon superheroes, has a superhero that's directly related to the Tuskegee study. It's called The Truth. It's a series, okay? Now that's all out in the public domain. Now you come along with a research study, trying to recruit someone. And you have to understand, in our communities, they think when you change their medication, you're doing an experiment. You know, that's not a clinical. You just switch, you got medication. They think they're being experimented on in the course of just normal treatments. So this is the backdrop. Now, if we had time, we'd have a similar example from the Native American experience, examples from the Hispanic experience, Asian experience. So many of the marginalized groups have experienced research abuse. Even whites have experienced research abuse. I'm talking about whites who have been diminished in some way, whether it's mental or even because they're elderly. So I'm going to take a chance. I got my crack tech team back there. They're going to work on the sound. I want to hit the word. I'm going to hit escape. Whoo! And I'm going to take a chance here to go full screen. Okay, get ready, guys. Not yet, but get ready. So one of the things that we've found is helpful is to take what the people tell us about their experience interacting with our healthcare system and then reenacting them in ways that we can use for our teaching. And so I want you to meet Mr. Green. Okay, guys, you ready? Here we go.
William Green is a 65-year-old African-American man with 3 grown children. For 15 years, he worked on the loading dock at the local Walmart, but was laid off after suffering a non-work-related back injury. Eventually, he found work as a security guard at a bank, but he currently has no health insurance. 1 year ago, Mr. Green noticed blood in his urine, but initially he was too embarrassed to mention the problem to anyone. After a few weeks, he began to feel pain on urination and went to the emergency room. At the emergency room, Mr. Green received a hurried examination and was given a prescription for antibiotics. After a week on the antibiotics, he returned to the ER since there had been no change in his symptoms. At the emergency room, he received a prescription for a second type of antibiotic. Once again, Mr. Green saw no improvement in his condition and returned to the ER. A third doctor suggested that he undergo a cystoscopy. It took Mr. Green 2 months to save up the $750 for the procedure, which revealed cancerous cells, and subsequent work has revealed bladder cancer. Today, Mr. Green will meet with an oncologist who would like to enroll him in a clinical trial to study the effects of a new cancer drug used in combination with the current standard 2-drug treatment combination.
Mr. Green, unfortunately, with the late diagnosis that you have, it has limited our options for how we can treat this. But what I can offer you is we do have a clinical trial that we've just begun that I'm researching at this point, where we have a 3-drug therapy. I really believe this would be your best option at this point.
Wait a minute. Don't you have anything positive to tell me? I mean...
I'm sorry. Unfortunately, at this point, we're not looking that this is something that could be curable, but what we can do is hopefully arrest its development.
Doc, I've been through hell. This thing started a year ago. It scared the death out of me with blood coming out of my urine.
I realize.
Too embarrassed to talk to my wife about it.
Unfortunately, with the delay that you had in seeking treatment.
I went to the emergency room 3 separate occasions. The first time I stayed there 2 hours and waited for a doctor who spent less than 10 minutes with me. Took a urine sample and sent me on my way. It was like I wasn't even there. A week later, I'm still bleeding. I go back to the emergency room. I wait another 2 hours. The doctor doesn't stay as long as the first one.
I understand. I have read.
Tell me this, doctor.
Mr. Green, I have read your chart.
I go back a third time. Then they tell me I got to have some cystoscopy or whatever the thing is.
Cystoscopy.
Why can't I have the surgery?
At this point, the surgery would not be something that would be beneficial to you. This clinical trial that I am doing now, we are hoping to look at a 3-drug therapy that will address the problem from another angle. Normally we do only a 2-drug therapy. That's what's standard now. But we're hoping that this 3rd drug therapy will come at it from a different angle, and that although we can't cure the cancer at this point, we could prolong your life, arrest its development a bit.
Prolong my life?
Yes.
What are you telling me? I can't have the surgery, so what are my chances without the surgery?
On average, with the standard 2-drug therapy at this point, we're looking at 9 months. But what I would like you to take a look at is this information I have on the clinical trial that we are starting. Now, the one thing that we do need to be aware of is whether or not you are diabetic. Do you have any history of diabetes in your family, or do you know that you are diabetic yourself?
No, I don't.
Okay. That would be our first step, that we would have you tested for diabetes. If you are diabetic, that would eliminate you from the possibility of joining this trial. But that's where we would like to start. So what I would like to do is set up an appointment with my nurse out in the waiting area so that we can start this right away, get you in the loop, and get you started here.
I got to talk to my kids about this. I mean...
Mr. Green, obviously you're aware that time is of the essence.
Yeah, I know, and I know you don't have a lot of time. I know you're a big man, and I see all the people following you around. You're very important, but what...
So don't talk to your neighbor. Don't say anything I'd have you write down the first thing. I'm seeing everybody's digital, so nobody has anything to write with anymore. So just take a moment. Let it soak in for a second. I'm going to get back to my slides, and we're going to open up a conversation. Okay, what did you hear or see? First thing that comes to mind, unfiltered. Start me out real loud. And tell me, you're a nurse. What do you do here? Just okay, medical student. I love it. Okay, what did you see here? What's the first thing that comes to mind? Real loud. It sounded disrespectful. Mr. Green sounded disrespectful? The doctor sounded who? The doctor sounded disrespectful. What did you see or hear?
The thing that gets done was kind of have too many conversations at the same time. Kind of have this essentially end of life conversation, but also talk about the trial and not pausing between any of those.
Okay, so multiple conversations, a treatment trial, end of life. You see, Mr. Green is trying to, go through everything he's been through in your hospital system. The specialist may not know any of that. Okay? Yes, real loud. And your background?
I'm Anthony Delaware. I'm an endocrinologist. I think the lack of primary care and access, like you found through inappropriate is serving in that role.
Okay? Yes, real loud.
I'm Samantha Nurse, and I just saw that they both were the clinical treatment of cancer and kind of move to that. And what kind of process where he was and where they were, and they weren't having the same conversation.
They weren't having the same conversation. Let's see if I can get somebody on this side. Yes, real loud. And tell me who you are. Okay, community education specialist. Tell us like it is.
Or not having treatment prior and not really connecting to the open story that obviously they were so wrong with and if you knew, I don't see why you would confront the situation, all the accountability is instead of doing
Empathy. Did you hear that word? Keep going. So she really broke it down. And, you might say, oh, Dr. Thomas, you're exaggerating. There's no Dr. Atkins like that. So let me just see. How many of you know a Dr. Atkins? Okay. You just don't want to be one if you can help it. But in our mentoring, we mentored those the way we were mentored. Okay? And if you're on the front lines doing clinical work, you know that our success in saving lives is what? Early detection. You see somebody showing up for the first time with advanced cancer in 2019, you say, what the hell's going on? How in the world are you showing up for the first time with stage 4 breast cancer? Unfortunately, that's not uncommon with African American women. So you can imagine the frustration in the researcher saying, what the heck's going on? Time is of the essence. Time is of the essence. Mr. Green says, I need to talk to my family. These are big decisions, okay? Now, that was Mr. Green Part 1. Then we put Mr. Green through building trust training, and we have a Mr. Green Part 2. But my host didn't give me enough time to give you Part 2. But what you do need to know is that Mr. Green learns empathy, active listening. He reaches out and touches Mr. Green, okay? Dr. Atkins, I'm sorry. See, somebody's paying attention. And so these are learned behaviors. They can be unlearned. So one of the things that we do is to take the transcripts of our interviews with our participants and then turn them into reenactments, like you've just seen, and use them for teaching. You folks do it here in your medical education with your standardized patients, am I right? Okay, so we have our standardized human subject. So I'm going to head to the finish line. I'm going to look around and ask you, where's my timekeeper? How am I doing here? We're good? I got 10 minutes. Okay. So I'm going to take you to the finish line. So one of the things that we have done in our work, in health equity work, is say, you know what, we need to reimagine how we're approaching both the problem and the solution. And in 2011, we published in the Annals of Public Health toward a fourth generation of disparities research to achieve health equity. And it runs something like this. You need to think about where you are on the continuum. First generation disparities research is focused on the existence of the disparities. We've been in those rooms, right? The incidence, prevalence, all the slides, charts, graphs. Very, very important, essential. Tons of publications. There are people who spend their entire career first generation. You never have to leave your office. You're behind a computer, great data set, good software, boom. Second generation disparities research explain the reasons why. Oh, those people don't have health insurance. That's why. Those people live in poverty. That's why. And we come up with all the different permutations of the why. Again, good data set, nice software, never have to leave your office. Very, very important. Third generation disparities research is to provide solutions. These are our randomized clinical trials. We run a randomized clinical trial. We find out what works, whether it's a drug, medication, or whether it's lifestyle behavior change. The diabetes prevention program was head-to-head against the medication, metformin, and lifestyle. Lifestyle won. That's why we don't see any commercials on TV about it. If metformin had won, we'd be seeing commercials out the wazoo, okay? So here we have the results of a clinical trial published in the journals, but nobody's implementing it. Nobody's delivering it. Nobody's transforming it. So how do I deliver it outside of the rigors of a clinical trial in the neighborhood? People think, well, that's somebody else's job. I'm going to write another article. We're going to do this again, okay? So we argued that it's time for a fourth generation, which we call action. We build on all the previous levels. We take the issue of race, not as a variable to explain away, but a variable to put front and center. We look at the structural determinants of health, and we recognize that any implementation in the community will not be perfect, but it is necessary in the face of the burdens of disease that we find in our communities. And so it's in that context that we look for wicked problems. A lot of my friends run away from wicked problems. There's a wicked problem, I'm going to go this way. I'm looking for wicked problems. What's a wicked problem? A social or cultural problem that is difficult or impossible to solve for many reasons, including incomplete or contradictory information, the number of people and multiple opinions involved, large economic burden. Can you imagine? Nobody wanted to look at the lead in the water in Flint. Because if I open that up, I've got billions of dollars we now have to deal with. That lid was open. But you think Flint, Michigan is the only place with high levels of lead in their water? Absolutely not, okay? So there are things that people don't want to look at because of the implications. And the fact that complex problems are typically offloaded to policymakers or written off as too big and cumbersome to solve. Aren't we seeing some of those too big and cumbersome to solve problems at our southern border with Mexico? Are we not seeing some of that? Okay. So we run to wicked problems. And so here's what it looks like on the ground in our effort to deliver interventions in our communities. One of the wicked problems that we've uncovered has to do with oral health. Isn't it interesting that we separate the mouth from the rest of the body? It's just amazing. I mean, I was working with some cardiologists. They said, look, I have a list here of 35 people who've been diagnosed with severe heart disease. They require a valve replacement. They've been approved. They have insurance to cover the valve replacement surgery. On the checklist, the very first item is what's called what? Dental clearance. He says, I've got 35 names on this list. These are the people who haven't had their dental clearance. I said, well, why do they have to have dental clearance? He said the bacteria in the mouth is like a guided missile. It will attack the valve. If they don't get the dental clearance, we can't do the surgery. Now, he says, I've got some of these people who've been back in the emergency room for a cardiac-related event because they haven't had their dental clearance. It's just amazing to me. And then he says that any artificial, a hip, a kidney, will be attacked if there's bacteria in the mouth. I said, well, how long do they have to keep it clean like that? You know what he said? The rest of their life. The rest of their life. He said, you hear about the valve because the valve will kill, but it will destroy a hip, it will destroy a kidney, it will destroy any artificial, okay? So you can see here about the problem, who has insurance and who doesn't, et cetera. And one of the things that we did is to reach out, partner with the Archdiocese of Washington, D.C., and hosted the Mission of Mercy. Raise your hand if you've heard about a Mission of Mercy. Just a few hands. Okay, you've heard about it. Raise your hand if you've actually volunteered at a Mission of Mercy. No hands. No hands. I'm going to fix that, though. What you see here is a line of people outside of the Xfinity basketball arena at the University of Maryland. We took our basketball arena and we put in 125 dental chairs. We went from cleanings to oral surgery with wraparound medical services. This was 6 a.m. in the morning. Because there was enough light for me to take this photo, the line went as far as the eye could see. The first person in the door at 7 a.m. was in line at 7 p.m. the night before. They slept outside overnight to get into the arena. We sent 1,500 people away, because exceeded capacity, okay? 11 miles from the White House. 120 dental stations, 1,451 volunteers, 1,185 people served, $1.5 million of free dental care. It's an underestimate because we only counted the dental care. I mean, our dentist will tell you how much crown costs, how much a filling costs, how much, okay? But none of the medical and the other wraparound services, we did not cross that out. I'm going to take a chance. I'm going to take you in this place. I'm going to hit a button. I'm going to ask my tech people, bring the volume up, and keep your fingers crossed, people. Here we go. Now, on this one, I want you to look very carefully at what you see.
That is such a sight to see hundreds of people being cared for this wonderful dental ministry. This is an act of care. Everything the Lord asks us to do to one another and for one another is being demonstrated right here. Just be there for a sister or a brother who has a need. What an extraordinary partnership. The Center for Health Equity, Catholic Charities, all under the umbrella of the university. It's extraordinary.
When you're in that arena, this is America, people. I'm 11 miles from the White House. Black folk, white folk, Latinos, Muslims. It's an amazing thing to see. At the end, people are crying, not because of pain. They're crying from joy of serving others. So, and you should know, we've been criticized for doing this. People shouldn't have to get their dental care in a big arena with thousands of other people. You know, we have gotten criticized. And our answer is this: until you fix the other big system, we have an obligation to alleviate human suffering. To alleviate human suffering. In the state of Maryland, this is done 4 times across the state. And the same phenomena. Thousands of people lining up for free dental care. Now, our model, we're one of the few because we have the infrastructure to bring the wraparound medical service. Did you see the people coming in? Okay, if we had time, we would deconstruct what you saw. You saw people who were very, very overweight, yes? You saw a man in a wheelchair, handicapped, paraplegic. You saw a lot of different things. Many of those people have the burdens of other chronic diseases. They would never sleep outside overnight to come figure out how to lose weight, eat better, follow the doctor's orders, okay? So we have to meet people where they are, where their needs are. And if you've ever had dental pain, come on, dental pain people. You ever had dental pain? It will drive you to do bad things, all right? So you end up in the ER. What do they say in the ER? Here's an antibiotic, okay, pain med, go see a dentist. And they can't see a dentist. So they show up at the Mission of Mercy. Now, because of what happened to DeMonte Driver, and if people in this room right here who cared for DeMonte Driver, the laws changed in the state of Maryland. So for children, this is all adults. For children, children are covered. But their mothers, their fathers, brothers, sisters, their adult lives and their families are not covered, which is why we see this phenomenon. So they came from across the region. It created opportunity for interprofessional education. Think about it. What other time do you have not just the dentist there, but the endodontist and all the dental specialties, the medical specialties were all there in the same place, under the same roof, same purpose. We conducted a whole range of research while the people were there in the arena. And because of time, I can't go through all of that. We had very high-tech machinery in that arena. We were able to move x-rays from the x-ray machine to iPads on the arena floor. We were doing things that people don't even do in their offices. And we published in some of the top journals about our observations and what we have found. And so we believe that this is a wicked problem, and it's not going to get solved anytime soon. You're not going to convince the dentist to start doing blood pressures. You're not going to get the primary care docs to start looking for gingivitis. It's broken, okay? It's broken. And I want you to know that in the meantime, we need to alleviate human suffering. So in September of 2019, September 12 through 14, the Mission of Mercy comes back to the University of Maryland campus. I want a Children's Hospital delegation. I want a Children's Hospital delegation to be there. I'm putting you on the spot. You need to know. Let me know if you have a boss in here I need to point to. Yeah, I want a Children's Hospital delegation. So there we go. We can't say he wasn't here. So that we can work together. If there's anything that we're doing in this country, you see we're being pulled apart. The one way we can come back together is in the arena of health. It is my belief, because it is all about taking care of one another. And so cultural tailoring really does matter. In 2001, the federal government launched their Take a Loved One to the Doctor Day. Great idea, but in our neighborhoods, nobody had a doctor. So we did a fourth generation and flipped it on its head. We said, let's take the health professional to the people. And so that's how we launched our barbershop health network. It's called HAIR, Health Advocates in Reach and Research. And as you can see, just in this one setting here, that happens to be a pharmacist talking to a young man who probably hadn't seen a doctor since he stopped playing sports, okay? But he's in the barbershop. And I'm just going to tell you the truth here. I hope my black brothers and sisters in here will back me up. No self-respecting black barber would ever say, I'll get you in and out in 15 minutes. All right? It doesn't matter how much hair you have. You might be there half a day. They're talking about sports. They're talking about this. They're talking about the other things. They got the TVs on. They got the music going. Everybody talking all at the same time. And I'm sitting there, and a guy comes in. His name is Joe. He says, Joe, where you been? He said, I was in the hospital. They told me I had a heart attack. They kept me for 3 days. Now, all the music's on, TV's on. And in that noise, there's a bit of privacy because he's talking to his barber. But everybody's still listening. And he pulls out of his pocket a vial. He says, the doctor told me I got to take these the rest of my life. And now everybody's listening. And the barber says, Joe, you know if you take those pills, you won't be able to keep up your obligations. And now, do I need to translate for you? Translation? Erectile dysfunction. Okay, so that's one of the side effects. And I'm looking at Joe's face, and I'm saying, Joe is not taking those pills. ER diagnosis, pills. He ain't taking those pills. I said, now what if that barber would have said, Joe, if you're having side effects, tell your doctor. They can adjust the dose. Talk about it. And that's where the idea is, and what if they're partners? Because there is information communicated in those spaces. His doctor has no idea this man has that much power. Now, because he's not taking his pills, he don't want to see the doctor. So he don't want to come back. Now, I used to think that the fear on his face was because he was afraid of his own performance. That's what I initially thought it was. But you know what I've learned later? It's not the fear that he can't perform. It's the fear of his wife or girlfriend saying, where you been? That you don't have any more juice for me. You must be out there running around, okay? That was his real fear. That he would be accused of infidelity. You follow me? That was his real fear. But a fear like that would prevent you from taking a life-saving medication. Okay, so here we are now out in the community. As you can see, I lost my man right here because he had his yarmulke on too. So I'm trying to say white folk have culture too. I have my Jewish brother here with his yarmulke. These two men probably would never meet other than this moment here in front of the barbershop. And this young man, it's actually summertime, and he's sitting there with his leather coat on. It's a cultural thing. He is still cool, trust me. And so hair has been written up as a book chapter. We have a number of examples. And this work here that was published in the New England Journal of Medicine, I think, really took it home. This is, again an example. Here's a clinical trial, randomized, gold standard, blood pressure control, black bar, hugely successful. Then they move on to the next study. What we do is we take this and now we implement this. We tailor it and implement it for delivery in barbershops across the country. If we had time, I'd take you into the shop. It looks like I'm a little over. I won't take you in the shop, but with time, hopefully this is the beginning, not the end of our relationship, my friend. And so here, as you can see in these scenes here, this last thing that popped up on the lower left is important because as a part of our conversation in these shops, this young man came in, his hair was like this big, and he shaved it off to donate it Locks of Love. He didn't know about Locks of Love. Donate it to Locks of Love. In this scene here, a group came in for their national meeting at National Harbor. They wanted to do something in the community. We had a pre-conference workshop. 60 physicians signed up. We sent a bus to pick them up, and we deployed them into the barbershops. There's a little video clip here. We don't have time, but when you see it, the physicians love it. They love being outside of the clinical setting. They love reaching people where people are more comfortable. And so we believe that this is a model that we want to take around the country. We'd love to figure out a way of partnering with Children's Hospital. And then how might technology help us build trust in these disparity populations? If we're not careful, this technology will exacerbate the very disparities we're trying to address. And so with that, ladies and gentlemen, I'll say thank you very much.